Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Naga Suresh Chipali from Albuquerque, New Mexico. Dr. Chipali is attending orthopedic surgeon at the Raymond G. Murphy VA Medical Center in Albuquerque and also clinical assistant professor at the University of New Mexico in Albuquerque. After his residency at the NTI University of Health Sciences, he worked as registrar in Northwest Regional Hospital in Tasmania, Australia. Subsequently, he pursued fellowships at the Sinai Hospital in Baltimore, another one at the University of Birmingham in Alabama, an adult reconstruction fellowship at the VC Virginia, and yet another fellowship at the American Sports Medicine Institute in Birmingham, Alabama. He has several publications in high-impact journals and has presented his work across conferences throughout the world. If you've noticed, Dr. Suresh has delivered a couple of lectures on our channel and it's already reached a huge audience. And today is my great honor to bring back Dr. Naga Suresh Chipali for this wonderful live program. Over to you, Suresh.
Thank you very much, Dr. Gopalan, for this kind introduction. Let me introduce myself to your audience. My name is Naga Suresh Chipali. I'm currently orthopedic surgeon at VA Medical Center in Albuquerque. And this is a great honor to be on this platform and talking about this very interesting topic, which is close to my heart. Alignment options in total knee replacement.
Yeah. Yes.
Yeah. Alignment options in total knee replacement. This topic is very close to my heart, and I have been following this for the last few years very closely. And as Dr. Gopalan has shared, this has been my journey. And thank you for everybody who supported me in this journey. Why alignment is important? So if you can see these images, the one on the right side is a Qutub Minar, and it has been built almost 900 years back. And it is a 72.5 meters, which has been tallest for a long time in the history, and it is still standing erect. The other one, this one is built, this is the Leaning Tower of Pisa, which is built around 600 years ago. And while it was being built, it leaned 4 degrees to one side, and they somehow managed to finish the building without a further collapse. But slowly, 100 years ago or 40 years ago, they noticed that it is starting to collapse. So they invested billions of dollars to prevent further collapse. So this building, of course, is a modern structure, and it has been built less than 50 years ago, but it hasn't followed the alignment rules, and it collapsed catastrophically. So this explains you the importance of alignment for anything. Alignment is quite important for longevity, and alignment is important to avoid aseptic loosening and wear-related issues. What is the past? So mechanical alignment and anatomical alignment have both simultaneously evolved. Probably mechanical alignment evolved a little bit earlier than anatomical alignment. But the mechanical alignment is the present right now, and the anatomical alignment has been the past. The reasons. Anatomical alignment has been developed by Krakow and Hungerford. So they aimed at a systemic oblique joint at 2 to 3 degrees of valgus. And distal femur is resected 8 to 9 degrees valgus to 8 to 9 degrees valgus to femur, and 3 degrees valgus to the tibia. Overall, normal tibio-femoral alignment has been maintained at 6 degrees of valgus. So they claim that the joint is parallel to the ground during gait. But despite anatomic alignment, it hasn't seen a future. The reason being that they have noted a significant aseptic loosenings and failures in their alignments, and the mechanical alignment has become more popular and widely spread and widely acceptable by orthopedic community. One of the other reason they quote is that while they were working on anatomic alignment, simultaneously they have used the carbon fiber reinforced poly, which was introduced at the same time, and carbon fiber reinforced poly has become a catastrophic failure. So we are not very sure whether the alignment has failed or the poly has failed, but eventually they both have been failed and they have been out of the market for a long time. So mechanical alignment. Mechanical alignment is the present right now. It's a in mechanical alignment, distal femur is resected perpendicular to the mechanical axis of the femur, and proximal tibia is resected to the perpendicular to the mechanical axis of the tibia. So mechanical axis is drawn from the center of the femur to the center of the ankle. The angle between the joint line and the mechanical axis of the femur is called mechanical LDFA, and which is 87 degrees, and MPTA, which is 87 degrees. These numbers are quite important for us to remember. When it comes to the anatomical alignment, this is called anatomic LDFA, which is 81 degrees. And anatomical MPTA is the same as mechanical MPTA, because the mechanical axis and anatomical axis of tibia are the same. In mechanical axis, after resecting the distal femur and the proximal tibia perpendicular to their mechanical axis, we also externally rotate the femur in relation to the posterior condylar axis to balance the gap in flexion, or to make a rectangular flexion gap. These are the three standard principles of mechanical alignment. And in mechanical alignment, to balance the gaps, both in flexion and extension, and to make a rectangular gaps, they will also release the tighter ligaments in the knee joint. So this has become a little bit controversial and not widely, even though it's very widely accepted, and people were not super happy to release tighter ligaments in the mechanical alignment. If you really look into a total knee, we sacrifice ACL. Let's talk about, let's take an example of a varus knee. For any total knee, we're sacrificing the ACL, and the LCL is already kind of elongated. And most of the times we sacrifice PCL for balancing the knee. So the only healthy ligament, or only ligament which is very competent, is a medial collateral ligament, and we are weakening the medial collateral ligament to balance or to make it equal to the weakened lateral collateral ligament. So basically, we don't have much ligamentous structures stabilizing the knee joint in a bad, severe varus knees. Same with the similar valgus knees. So we release the lateral structures to make it as lax as medial structures. So probably, like a lot of newer thinking is that probably significant capsular release or significant ligamentous release is the cause for dissatisfaction following total knee replacement. So what's the future then? The future could be mechanical alignment, or could be adjusted mechanical alignment, and there are several terms that have been introduced. Restricted kinematic alignment, restricted kinematic alignment, inverse kinematic alignment, inverse restricted kinematic alignment, functional alignment, and personalized alignment. I'm going to go through each and every step or each and every principles of alignments in this talk, and try to make you familiarize with this topic. Alignment in total. It's not it's not a newer concept. This article has been published by Freeman in 1980s, and this article has been published by Haddad et al. In 2020. So we're still talking, despite 40 years of, or 40 to 50 years of evolution of total knee replacement, we're still talking about alignment in total knee replacement. There's no drastic change in the human evolution. There's no drastic change in the physics and mechanical properties, and no significant changing in the cementing materials and techniques. And there are some improvements in implant designs. Probably we have more number of options in implants than before. And we have some significant improvements in the plastics, and surgical precision has been better than before. While in last 40 to 50 years, we are talking about alignment in total knee. The science has drastically progressed. So internet has evolved, robots have evolved, space tourism is there. People are reading human brain, and people are reusing rockets, and electric cars are there. So I'm trying to say that we are still significantly behind as a medical community when compared to the scientific world, or at least as an orthopedic community, we're significantly behind when compared to the rest of the scientific world. Well, if you consider total knee replacement as a drug, normally what we do is we do a randomized study and get the results and get it approved by FDA. But in the surgical world, this is not possible. So that's the reason we do the other way around. We perform the surgeries, and then we evaluate, and then we will see whether we are up to the mark. So the question we asked ourselves after 30 years of surgery, or after 30 years of surgery, are we meeting the expectations? And multiple studies and from multiple countries have revealed that 20 to 15% of the patients have been unsatisfied, and the younger the patients are more unsatisfied, and there is a significant scope of improvement. And since then, multiple technologies and multiple designs have evolved. So let's go back to the basics. There's a vertical axis of the body, vertical axis of the lower limb, femoral mechanical axis, tibial mechanical axis, joint line obliquity, and femorotibial axis, and hip knee ankle axis. So vertical axis of the body that goes through the pubic symphysis and in between the knees to the in between the ankles. And the next one is the mechanical axis of the lower extremity, which goes to the center of the femur and center of the ankle. If you clearly or if you pay close attention, the angular difference between the vertical axis of the body and the mechanical axis of the lower extremity is 3 degrees. This 3 degrees is quite important, and we'll go through it later. And the mechanical axis of the femur goes from the center of the femoral head to the center of the knee. Same as mechanical axis of the tibia, it goes from the center of the knee to the center of the ankle. And it's quite important to understand the angles, the anatomical LDFA and NPTA angles, at least have a visual memory of these angles. Mechanical alignment. Did we miss considering a few things? So mechanical alignment has been a systematic approach for a TKA implantation, and it's a systematic goal. So it is not a very personalized, and we noted that people have a different alignment in their knees, and it's a standardized total knee for everyone. So probably people have a different functional abilities and different constitutional alignment, and having a goal or having one goal for everybody might not be appropriate. And the mechanical alignment completely ignored the joint line obliquity. And there 30% of the people have constitutional errors. However, I want to say that mechanical alignment has excellent survivorship, and the functional outcomes are little bit disappointing, but they are very much acceptable. And this is how we do mechanical alignment. The joint line obliquity that I'm talking is, so if you see this red line, this is the normal joint line obliquity. Once we do the mechanical aligned knee, the joint line obliquity is lost, and sometimes you see upsloping or more valgus. And also it's noted that in single, double leg and single leg stances, the joint line obliquity, like if you are in a single leg stance, the joint line is perpendicular to the ground reaction forces. So the static alignment might not predict the dynamic tibial plateau loading. So look back into the literature, like, we have concerns about mechanical alignment, then why it has become so popular? Again, as I have been telling you, mechanical alignment has at least 80 to 90% of satisfaction rate at this time. They have excellent survivorship, and multiple studies have proved this one too. However, and varus alignment greater than 3 degrees had more failure than valgus alignment, and neutral mechanical axis has less loosening when compared to the other alignments. And the implant survival rate, as I told you, has been extremely well for a neutral alignment, and polywear is significantly worse with the varus alignment. So there's a lot of information saying that neutrally aligned knee replacement has a long-standing value. However, most of the previous values have been sorry. However, if you look into most of the previous studies have been based on the short radiographs. And Pagnano, he's a professor from Mayo Clinic, and he has done a study for a 15-year survival of modern cemented total knee replacement, and he evaluated the patients with long-standing hip, knee, ankle x-rays, and has realized that a mechanical goal of plus or minus 3 degrees has a little practical value for predicting the durability of the modern total knee arthroplasty implants. And after this publication, the debate about mechanical alignment has triggered, and we kept on asking, is mechanical access is for everybody? So, and the concept of constitutional varus has evolved. We noted that at least 30% of the people had more varus, and varus knees are heavy in sports activity people. And for a patient with a constitutional varus, if you want to make it balanced, mechanically aligned, we will end up sacrificing a lot of MCL. So, so we ask this question: is varus alignment is that bad in total knee replacement? So it is noted that varus malalignment has no influence on the clinical outcome and the midterm follow-up after total knee replacement. It's also published that residual varus alignment does not compromise the results of total knee replacement. And in fact, some people have promoted that slight undercorrection following total knee arthroplasty results in superior clinical outcomes on the varus knees. So based on this, this concept, this philosophy has evolved: adjusted mechanical alignment. The goal is to undercorrect the constitutional frontal deformity to a maximum of 3 degrees. So slight to moderate deformities are preserved, and usually they adjust a few degrees on the femoral side and a few degrees on the tibial side in a severe deformities. Where do you want to adjust in a severe varus? Do you want to adjust in the tibia, or do you want to adjust in the femur, or both? So there is a biomechanical study saying that adjusting varus means like doing a tibial cut in a little bit varus has a more or is better for contact forces, and also it's more friendly on the soft tissue. If you look here, if I resect a tibia in varus, the distance between the medial collateral ligament attachment and the joint line will be maintained. And if you end up doing varus in a femur, so my joint line is elevated, and the distance between the joint line and the proximal portion of the medial collateral ligament is significantly decreased, and it can cause abnormal stresses across the MCL. However, there is a clinical paper saying that femoral component in varus malposition is associated with the tibial aseptic loosening after total knee replacement. So do we need to do varus cut in both sides? So, and there is a paper saying that the varus, when you adjust the varus cut on both sides, the functional outcomes are superior to the normal mechanical alignment. Kinematic alignment. So Copernicus is the one who first told that Earth and all other planets revolve around the sun, and in alignment world, Steve Havel says that entire knee revolves around the femur. So he is the one who first introduced the kinematic alignment, which is not totally different from anatomical alignment, but has a significantly improvised version of anatomical alignment. In kinematic alignment, the goal is to restore the pre-arthritic alignment and a well-balanced artificial joint through whole range of motion, and recreating distal and posterior femoral joint lines, and recreating joint line obliquity, and no ligament release. So he mainly professed three axes in kinematic alignment. One is a transverse axis, where tibia flexes and extended, located in the center of the circles inscribed by the femoral condyles. And the transverse axis 2 is where patella flexes and extends, and parallel to the patellar axis. And third one is the longitudinal axis in the tibia. Tibia internal and externally rotates on the femur. Let's quickly compare the difference between the techniques of mechanical alignment and kinematic alignment. We talked about axis. In mechanical alignment, we aim to keep mechanical axis or hip, knee, ankle axis to neutral. And in kinematic alignment, it is based on the three axes, which I have briefly described a minute ago. In mechanical alignment is mainly based on the transverse epicondylar axis, whereas kinematic alignment is based on the cylindrical axis. The femoral component rotation. In mechanical alignment, we tend to externally rotate to balance or to make a rectangular flexion gap. In kinematic alignment, we don't do that. There is a difference between transverse epicondylar axis and cylindrical axis of the femur. Distal femur cut is made perpendicular to the mechanical axis of the femur. And in kinematic alignment, we measure we estimate the amount of the cartilage loss or arthritic wear to the bone. And then we take equal amount of the bones from the medial and lateral femoral condyle. As I explained to you, there is external rotation of the femoral component in mechanical alignment to make a rectangular flexion gap. and we don't do that in a kinematic alignment. As a result, the posterior cardiac thickness are unequal in a mechanical alignment, and they are equal in a kinematic alignment. Tibial cut is made perpendicular to the mechanical alignment of the tibia. In kinematic alignment, based on the deformity, most likely we end up doing a 3 degrees varus cut on the tibia, but the number is not fixed. So we try to cut tibia based on our femur cut, and we try to make a rectangular extension space. And the slope, they try to manage the slope of medial tibial plateau. And tibial component rotation is based on tibial tubercle in in mechanical alignment, whereas in kinematic alignment, they draw is along the axis of the lateral tibial plateau, because that's where the femoral rollback happens along the lateral tibial plateau. Gap balancing, we aim to manage equal rectangular flexion and extension space in mechanical alignment, whereas in kinematic alignment, there is equal rectangular space in extension, but a little bit lax and a trapezoidal gap in flexion. So owing to these differences in techniques, we have asked this question: is there enough evidence for kinematic alignment? Implant survival and function of 10 years after the kinematic alignment total knee replacement is excellent. A study done by Dr. Holland, and it is multiple kinematic studies have revealed that it functions like a normal knee, and a kinematic alignment restores better natural tibiofemoral kinematics compared to the mechanical alignment. And the meta-analysis also have revealed that kinematic alignment at least do as good as a mechanical alignment. The other question I asked is the KA superior to a mechanical alignment? Except a few studies which have shown some slightly increased satisfaction rates, there's no significant difference in the outcomes between the kinematic alignment versus the mechanical alignment. And the satisfaction can be multifactorial too. Other question I asked to myself is: kinematic alignment is suitable with current implants? So current implants have been designed mostly for mechanical alignment with valgus trochlear angle and very straight keel. Whereas when you are using a short stems, probably the kinematic alignment does not, these implants does not matter much, but however, it is whenever occasionally we experience some osteopenic bone and we wanted to add an extended stem, and in kinematic, if you are planning to do a kinematically aligned knee, it will become a challenge to add a stem to it. And also, it's also noted that kinematic alignment of current total knee implants does not restore the native trochlear anatomy. Can KA be used for every knee? That's another question we asked. There are some knees we see with extreme deformities, extreme valgus deformities and extreme varus deformities, and if we use kinematic alignment, then we'll be in big trouble. So, and it is noted that there are wide variations of MPTA and LDFA. So probably kinematic alignment is not used to or useful for every deformity, especially in extreme deformities. So Professor Vendotti has come with a little bit modification of kinematic alignment, which is called restricted kinematic alignments. In order to avoid extreme component positioning and severe deformities, he came with an algorithm. It came with like, if the deformity is small, he follows the regular kinematic principles. But if the deformities are large, he tries to maintain the MPTA and the LDFA to 5 degrees. And in another study, it is noted that at least 50% of the patients needed a restricted kinematic alignment, whereas 51% of the patients can get away with unrestricted kinematic alignment. What is this inverted kinematic alignment? So inverted kinematic alignment, here tibia has become the sun. Everything revolves around the tibial cut. Tibial cut is usually first performed, and they evaluate the deformity, and they decide whether tibia needs to be cut at varus or valgus or neutral, and based on tibial cut, they resurface the femur to make a, they resect the femur to make a rectangular extension space. And femoral component is rotated appropriately to make a flexion, rectangular flexion space too. And there is a paper saying higher satisfaction rate in total knee replacement using restricted inverse kinematic alignment compared to adjusted mechanical alignment. The difference, the major difference between adjusted mechanical alignment versus kinematic or inverse kinematic alignment is the joint line obliquity. When you have an adjusted mechanical alignment, the joint line is more like has a reverse slope or varus joint line obliquity, whereas kinematic alignment maintains the joint line obliquity. So what is this functional alignment? Functional alignment is basically has developed after robotics have entered into our arena. So 3D planning of a total knee replacement is done before the bone cuts are done, and soft tissue sensors are used to detect the soft tissue imbalances. And adjustments can be done with the implant positioning and soft tissue releases and or bone cuts. Femoral condyle can be aligned to a TEA within 3 degrees of freedom. So that's how we do it. So at the end, if you look how the alignments are going to look like. For a constitutionally varus knee, if the mechanical axis goes medial to the medial tibial plateau, uni knee replacement is not changing the alignment at all. Kinematic knee replacement is also doesn't change the alignment, it just resurfaces the tibia, the femur. Whereas a restricted kinematic alignment or adjusted mechanical alignment have some goal of modifying the alignment. If you look carefully here, the joint line in restricted kinematic alignment is very similar to the, kinematic alignment is very similar to the native joint line. And with the adjusted mechanical alignment, the joint line obliquity is the opposite way. So what can we expect? So I think in future we can expect to evaluate the deformity very closely. We got to ask you the question: is this deformity caused by the tibia, or by cartilage loss, or by the femur, or by the ligament laxity, or is caused by any metaphyseal bowing or extraarticular deformity? And for every case, I guess we will end up drawing MPTA and LDFA and hip knee ankle alignment. And we also evaluate the gait patterns and the future requirements of the patients. And we define ideal alignment specific to that patient. And I think no more one size fits all approach will be the way. And Thank you very much for this opportunity, Gopalan. So,
Thank you, Suresh, for yet another brilliant talk of yours and covering the entire spectrum of alignment. Just a few questions from our side. Suresh, we are targeting exactly the 10 to 15% of patients who are not satisfied with a conventional total knee, right? And we assume that a kinematic knee would solve the issues. But do you think that 10 to 15% is solely because of this kinematic versus mechanical issue? There are other issues like pain tolerance between every patient. Every patient is different, isn't it? And there could be other factors. Because every paper we read, the reason why people go for kinematic alignment, they say that, okay, we want to address that 15% of patients who are unsatisfied with the conventional TK.
Yes, I agree that like patient satisfaction is very multifactorial. It all it's a super subjective, but large, when you use a large database studies, the 10-year survival rate and the patient satisfaction rate has been a little bit improved with the kinematic alignment. I'm not saying that this is going to be panacea. We still have a lot of work to do to find out what would be the best strategy to improve the patient satisfaction. When you talk about total hips, we don't talk about dissatisfaction in total hips. And we're talking about the same patient population, the pain issues and all other issues. But when it comes to a total knee replacement, it is a totally different animal. So we have a lot of unsatisfied patients. So I strongly feel that there is some scope to improve in our total knee replacement to reach at least as good as total hip replacements.
Thank you, Suresh, for that. And when you look at the surgeon's perspective, understanding is, I mean, when most of us learn TK through the mechanical way, and then in case we want, we shift to kinematic. And a surgeon needs to be even more precise, right? You need to measure those resections. You need to take the calipers. You need to look at whatever you said, the posterior condylar and the lateral femur, isn't it? So
Yes,
is it more complicated than the conventional mechanical TK?
I think what I believe that kinematic alignment is a philosophy, and the philosophy is mainly talking to restore the joint line A and to minimize the soft tissues releases B. For a neutrally aligned knee replacement, either of those things don't have any significant impact. But in some extreme deformities, when you end up releasing a lot of soft tissue releases, the mechanical alignment patients will be more unsatisfied, and those things could be avoided. And regarding the complexities of the total knee replacement with the kinematically aligned versus mechanical aligned, yes, it makes for us, because we learned through mechanical alignment, for us to change to a kinematic alignment technique, it makes it more complicated. But if I'm talking to a medical student, it makes more easier for a medical student to just to resurface what is lost, you know. So you're not really rotating anything. There's no complex process involved. You're not releasing any soft tissues. You see the knee and you just estimate that there are 3 to 4 millimeters loss on the medial femoral condyle, and you replace that with some dowel there, and then you resect distal femur. And then you place your guide very parallel to the tibia according to your femoral cut, and you resect a tibia. And there's no external rotation involved. It's less complicated for a non-trained brain. This is my perspective.
Okay, so in that case, suppose someone has trained exclusively in kinematic knee, it would be much easier for him rather than someone who's gone through mechanical and then shifting to kinematic, isn't it?
Yes, yeah, because this is all the philosophy changes, you know, so those things, it doesn't happen on one day, you know, so this philosophy has been ingrained on us for almost 20 years, and then suddenly somebody's coming and changing that you don't need to do externally rotate, where we have been struggling to find transverse epicondylar axis in the surgery, and then we excel in that, and somebody will come and is changing your philosophy. Yes, it is a difficult transition for sure.
Suresh, just one last question before we wind up the session. See, in your presentation and elsewhere, we have learned that younger patients are the people who are not that well satisfied with the conventional mechanical alignment. So do you think there is any data to say that a kinematic alignment is superior in a slightly younger patient?
I haven't come across any such data.
Do you think that makes sense? Because younger patients are not satisfied, so let's try kinematic alignment in them, and in the other ones, let's do mechanical.
So I'll tell you something. I think the future is going with less ligamentous releases. So in younger patients, most of my younger patients have been extremely athletic in their younger age, and they ended up having some constitutional variants. And with this athletic injuries, they ended up having this knee deformities and arthritis. And in those cases, when I had to go and when I try to aim for mechanical alignment, I'm stripping off entire MCL, I'm taking PCL. The tibia femoral articulation is managed by very weak, soft tissue envelope. And they want to be in the same active like before. So I think that's where the dissatisfaction is. What I am envisioning is that I think some malalignment can be accepted without sacrificing total soft tissue willingness. That's what I cannot say that whether it's going to be a kinematic alignment is going to win, or inverse kinematic alignment is going to win, or the functional alignment is going to win. I think everything might be around the same. The outcome might be the same. And I like to take an approach of a moderation. In the extreme deformities, I don't think so. Going the kinematic alignment, using strict kinematic alignment principles would be appropriate. How I do at this time is that I don't mind resecting the tibia 2 to 3 degrees varus in extreme varusness, but I still use a mechanically aligned principle, and I try to release soft tissues as minimum as possible. And I'm trying to retain PCL as much as possible too. Like having said that, if I had done 1,000 cases, at least 900 of my cases have been PS knees, and 900 of cases of mine are like mechanical alignments. And I used to, in the past, I used to think that not releasing the soft tissue is a kind of a severe negligence for a joint guy. And now my thinking process has completely reversed. Probably releasing the soft tissues, I have decreased my releasing of soft tissues by changing the bony cuts.
Thank you, Suresh. I think that's all the questions that we have for this session. Thank you for yet another fantastic lecture. And I'm sure this is going to benefit a lot of people all over the world. Thank you so much for joining in.
Thank you very much.